Hi, I'm Dr. Donald Jurovich. I'm a professor of geriatrics at the University of North Dakota. Today, we have a presentation on prevention in older adults, and this is a project through the Dakota Geriatrics Program, which is a federally funded HRSA program called the Geriatric Workforce Enhancement Program. So the objectives for today are to firstly align preventive services with older adults' remaining life expectancy, as well as considering their cognitive status. We also want to talk about how to apply the annual wellness exam enhanced with geriatric assessment. Topics covered include cancer screening, other preventive measures, lifestyle counseling, geriatric syndromes, immunizations, recommendations for chemoprophylaxis, and then finally the annual wellness exam. I just want to mention that I'm including various artists in this talk and may make comments periodically in relationship to each slide. This particular painting is a self-portrait by Grandma Moses, who was a Vermont painter who started painting when she was 76 years of age and lived to be 101. So prevention needs to be guided by remaining life expectancy of the older adult. Generally, we use most of the screening measures for individuals who have greater than 10 years of remaining life expectancy, although we need to consider highly functional individuals who may have less remaining life expectancy. And then we need to consider excluding preventive measures for those individuals that have moderate to severe dementia. Furthermore, functional status is always important in considering preventive measures, particularly if there's advanced functional impairment. And of course, if somebody has 6 months to 1 year of remaining life expectancy, appropriate for hospice or palliative care, those individuals too would be excluded from preventive measures. So it's important to have our prevention efforts align with what matters to the older adult. And we want to consider not only the length of lifespan, so the quantity, but we also want to consider the quality of life. And the whole goal is to really maintain functional independence. In terms of cancer screening, the goal is to identify cancer in order to prevent morbidity and mortality. We need to balance that with the cancer screening harms, which include anxiety, complications, false reassurances from false negatives, and then also overdiagnosis, where discovery of a tumor may not really impact the lifespan, and this is certainly seen in prostate cancer with older men. Well, why even do cancer screening in older adults? And the answer simply is for colon cancer screening, the incidence increases with increasing age. And so you can see the information here from most recently from 2020, where the rate per 100,000 population basically goes up exponentially, as you can see at the end of the bar graph here for 85 and older that have the highest incidence of colon cancer. But the good news is that colonoscopy, which is recommended every 10 years without any associated complications, results in a lower incidence rate of colon cancer. And you can see how things have progressed over the last couple of decades, where the incidence rate of cancer has gone down considerably, by the increased use of colonoscopy. So what are the screening tests for colorectal cancer? You can see the recommendations here for 50 to 75-year-olds. Certainly the fecal occult blood test every 5 years would be one recommendation. Colonoscopy or CAT scan colonography or flexible sigmoidoscopy would be all reasonable interventions or assessments, whereas in the 76 to 85-year-old group, really the idea of testing through any of those measures mentioned above for the 50 to 75-year-old need to be taken in accordance with what the patient's overall function and health status may be. In individuals over the age of 85 years old, no colon cancer screening is recommended simply because of the remaining life expectancy would not be there to justify further cancer screening. What about breast cancer screening? So it's important to discuss mammography at least every 2 years if there is greater than 10 years life expectancy in older women. So just remember the average life expectancy for women is 81 years of age. There's no evidence that mammography improves survival in individuals over the age of 75. And when we look at the impact of clinical and self-breast examination, there's not a lot of good data to support either. However, it is generally recommended that a clinical breast exam be done as part of a annual physical exam. In terms of cervical cancer screening, the recommendations are to have Pap smears every 3 years, or if you combine it with HPV testing, that would be done every 5 years. And basically, you can stop at, after the age of 65 for women that have had 3 consecutive negative cytologies by Pap smear or 2 negative papillomavirus screenings prior to the age of 65. And this discontinuation of Pap smears can be done regardless of the sexual history or new sexual partners that might be associated late in life. In terms of prostate cancer screening, it's not recommended to do screening for men over the age of 70. It would be good to discuss the prostatic serum antigen with what we call the young old, those that are between the ages of 65 and 70. And it's important to point out that 80% of positive PSAs may come back as false positives when you have a fairly low threshold of 2.5 to 4 micrograms per liter. In terms of lung cancer screening, it's now recommended that low-dose computed tomography be done in 55 to 80-year-olds who have had a 30-pack year smoke history and currently smoke or have quit within the past 15 years. So the level of evidence for that is quite good. It's level A. In terms of stop screening, these would be individuals who have not smoked for 15 years. And the other aspect is that if the surgical intervention wouldn't really improve life expectancy, or I might also add if they have low functional status, those would all be indications for not screening any further. And of course, if the patient says, I just don't want any further additional screening because I wouldn't have surgery anyways. All right, so the United States Preventive Task Force indicates that there's insufficient evidence to recommend things such as a whole body skin exam. If a dermatologist does it, maybe a little bit better. Screening for cancer of the oral cavity, urinary tract bladder, or thyroid is not indicated as a routine measure. The tough one in terms of ovarian cancer, there's no recommendation for screening for cancer antigens, ultrasound, or pelvic examination. Although I will point out that older adult women that may complain of bloating or fullness, that could be one of the signs of ovarian cancer. So based upon symptomatology, it may be important to follow up with some of these tests. However, just as a routine screen, it's not recommended. And again, no screening pelvic examinations in asymptomatic women. In terms of, again, asymptomatic older adults, bacteriuria should not be tested with urine analyses. asymptomatic individual should not get carotid duplex ultrasonography. There's no a point for screening hyperlipidemia with LDL if they're completely healthy. And then also, there's not necessary to do treadmill exercise testing if there's no history or symptoms of coronary artery disease. So the other aspect of screening against asymptomatic older adult, different thoughts here is that glaucoma should not be routinely screened, although I'll point out that glaucoma screening is part of the Welcome to Medicare exam, and Medicare does pay for it. But there's no evidence that spirometry tracking of COPD makes any difference in health outcomes. Again, healthy individuals who do not complain of symptoms of obstructive sleep apnea don't warrant a sleep study. Routine screening for osteoporosis is not really recommended unless there's risk factors. In terms of peripheral vascular disease, routine use of ankle brachial index is not recommended. Generally, if you can't feel a pulse, then that would be an indication that there is a sign of arterial insufficiency, and that certainly would warrant a ABI request. And then in terms of thyroid cancer, there's no evidence that palpation really improves the detection of thyroid cancer, which is disappointing in individuals like myself who teach physical diagnosis to medical students. And we always talk about the importance of the neck exam as one of those elements that they need to learn. In terms of hypertension screening, it's recommended that it be done. However, if the blood pressure is elevated, that it needs to be confirmed in the home setting. And so it's important to have a home blood pressure cuff measured or calibrated with the clinical, so that the individual will know that usually they're automated blood pressure cuffs, and so you want to have a correlation to make sure that what they're testing. But generally, most studies show that home-based blood pressure measurements are about 10 millimeters of systolic mercury lower than what you find in the clinic. And whether you want to call that white coat hypertension or otherwise, the studies are pretty confirmatory that there is a major difference between clinical measurement of blood pressure and home-based measurement of blood pressure. Well, in terms of diabetes, I have a painting here by Diego Rivera of the larger BMI individual, and typical in older adult healthcare that's predisposed to type 2 diabetes or prediabetes. And so the American Diabetes Association recommends screening all adults over the age of 45 with either a fasting blood sugar, hemoglobin A1C, or a glucose tolerance test. And the United States Preventive Task Force recommends screening older adults between the ages of 40 and 70 who are overweight or obese. So just a little bit more refinement in one case. And I bring both of these groups' recommendations just to show that there are some small variations with actually each different kind of screening recommendation. So we always have to keep those in mind. In terms of aortic aneurysm screening, basically one-time screening for men over the age of 65 who've ever smoked, whereas there's equivocal evidence, if you will, for selective screening of aortic aneurysms in men who have never smoked. For women, it's not so much recommended. In terms of osteoporosis screening, so all 65-year-old women and all younger old women who are at high risk should be screened. And a DEXA scan should be considered for men, particularly those over the age of 80. I just want to do a side commentary here that Diego Rivera was the significant other of Freda Kahlo, who's we saw earlier here with, and Freda Kahlo always had a lot of her paintings with hearts and arterial systems connecting the lighter side here on the left and the darker side of her personality on the right. In terms of screening for hyperlipidemia, we know that statin use decreases all-cause mortality in what we would call middle-aged and young old, so those that are age 65 to 75 years of age. However, the combination of studies, PROSPER, JUPITER, and HOPE-3, indicated that the statins were associated with a modest reduction in cardiovascular disease, but really no benefit in overall mortality in those that were 75 years and older. And part of the problem is that a lot of the risk calculators, once you hit the age of 75, everybody's got excessive cardiovascular risk. And so, basically it would mean that everybody over the age of 75 would need to be on a statin. And there may be some discussions about the value of that, but I think by and large, the average life expectancy, again, for men is 78 and for women is 81. So you're already under that 10-year risk factor already just based upon average life expectancy. So from that rationale, it does not make sense to consider statins at those higher age groups. Well, decision-making about statins, there's a reference here to Statin Decision Aid by the Mayo Clinic, so I'll refer you to that. Just kind of point out the Salvador Dali double imagery here, where in the middle you might see a goblet, and then you also see an older woman and an older man, but both of them are, you have a older senorita and a guitarist here on the right. So there's a lot that's hidden in the Salvador Dali surrealism, and so too in geriatrics. We often have to dig deep to find some of the problems that are not always facing us. In terms of hepatitis screening, there should be a one-time screen for hepatitis C, basically in the baby boomers. And we should screen adults at high risk of infection with hepatitis B surface antigen. Those are certain professions, phlebotomists, providers, healthcare providers, researchers, and those with alternative lifestyles. Healthy lifestyle counseling. So part of the issues here is that we want to promote physical activity. It's a tough one, but we'll talk about that a little later on in this presentation about best strategies and what actually you need to prescribe. In terms of nutrition, it's important to identify older adults with 5% weight loss in the past 6 months, or if they have a BMI less than 20. In terms of alcohol, well, we'll talk about alcohol screening, but I think it's important to point out what I call the 2-for-1 rule, which basically is that for each single drink of alcohol, they're equivalent in terms of metabolism to 2 drinks. And so I think it's always important to tell or explain to older adults that their metabolism changes with age, and that 1 martini that they may have in the evening may actually equal 2 martinis, and so forth. So the 2 beers are 4 beers, and it goes along with the impact that the higher drinking level will have. And I think that's important, particularly for individuals that may have falls. In terms of smoking, it's always important that you use each visit as an opportunity to stop smoking, no matter what the age, because it's been demonstrated that smoking cessation, even in your 70s and 80s, does result in some improved airway adaptation and responsivity. And we'll show some data about that later on in this presentation. In terms of counseling on STDs, usually I find individuals that are considering transferring from a private residency into a retirement community, that probably would be the best opportunity to talk about sexual activity, particularly if they're a single individual. As it turns out, and we'll see in a little bit, that STDs are on the highest rise amongst the 65 and older age group in the United States. In terms of latent TB, you want to consider immigrants, refugees who have come from areas that were exposed or have high exposure to TB, and I'll show you a heat map a little later on as to where those areas may be. In terms of prescribing physical activity, I think the most important thing is to set a mobility goal. I think everybody knows they should have a walking program, and there was a a great story of a 82, 83-year-old gentleman who came to my clinic, and his daughter also came with him, and she says, "Oh, I'm really worried about my dad because he's on the treadmill like all day long." And I asked him, I says, so is that true? Are you on the treadmill? And I said, and he goes, yeah. He says, so I said, okay, well, that's fine. And then the daughter stepped out for a phone call, and I asked him, I said, why are you on the treadmill all day long? And he goes, oh, it's because the babes are there. It's really easy on the eye. So I thought to myself, at the age of 82, all the better, buddy. In terms of set goals, is that we know that 5 miles walking a day is pretty much the cutoff that we want for improving health outcomes. Separate from the steps acquired daily are just basically aerobic exercise, which could be either through walking or bicycling or other forms of exercise, even dancing. That you have moderate intensity exercise for 30 minutes, 5 times weekly, so a total of 150 minutes. However you get those minutes. They all don't have to be at once, too. You could do like 15 minutes in the morning, 15 minutes later on in the day. We don't recommend physical activity after dinner because that really disrupts the sleep cycle. There's increasing information that high intensity is superior in some cases. We don't know this for the older adult, certainly for the younger individuals. So you can actually reduce your cardiovascular mortality by 40 to 50% with high intensity training. So there are some programs now for high intensity interval training, but it remains to be seen whether the older adults benefit from that so-called HIIT, H-I-I-T. And so that's ongoing research is the bottom line there. The aerobic exercise needs to be combined with twice weekly resistance training, and some people advocate that you do the resistance training for a couple of weeks, up to 4 weeks before you start an aerobics program, because you want to build up muscle mass, your lean body muscle mass, and you want to build up consequently the mitochondrial load to help with the energetics of the aerobic exercise. And then finally, we want to add core and balance training. So those are things like yoga, doing the tree pose, or Tai Chi is proven to be of great impact on core balance training. And then also various forms of dancing. And apparently it doesn't matter which style of dance you pick. It actually has the added benefit of socialization, which is probably a bigger longevity boost than the aerobic exercise itself. In terms of nutrition, it's kind of interesting that BMIs between 25 and 29 have the lowest mortality risk. So this came out of the Baltimore longitudinal study that showed a slight benefit towards reducing mortality in people that were just a little corpulent, but not too much. So that's just kind of curious, and some people think that that's because it's of a nutritional reserve or caloric reserve, that when people get acutely ill, that kind of balances things out. However, individuals greater than with a BMI greater than 30, they have increased mortality. They have a reduced overall functionality. And so weight loss in those individuals would be important, but it would be valuable to combine that with exercise, and for the primary reason that you can have older individuals that are obese that have sarcopenia, which is loss of muscle mass. So you don't want to further compound it by caloric restriction, and they actually should be on high protein diets to avoid the so-called sarcopenia. So Epidemiologic studies show this final point here that 15% of older adults are malnourished, and you could do a more refined screen. I like the Nestle Mini Nutritional Screen. Also, the St. Louis Rapid Geriatric Screening contains a good nutritional, a quick nutritional screening tool also. In terms of alcoholism, there's two tools that you can use. I prefer the Michigan Alcohol Screening Test, but the other one is Audit. We're no longer using CAGE because that's not as sensitive or specific in the older adult population. And I just kind of want to point out that the highest risk for alcoholism in the older adult population happens to be white women who have recently retired from their jobs. So just kind of an epidemiologic note there as to who might be a target for your alcohol screening. I also want to point out that I have prescribed a glass of wine to some of my older patients because of the cardiovascular benefit. However, that's balanced by the negative effects, obviously, with the reports of any alcohol increases the risk of cancer at all ages. Yeah, so this is the smoking cessation point that I wanted to make. Basically, the approach is to try to identify a quit date, to discuss the types of therapies that will be part of the smoking cessation program, and really to have then close follow-up either by a health coach, if you're in a patient-centered medical home, or by the provider, and to do so on a regular basis to see how things are going. However, I wanted to point out in terms of getting individuals to consider stopping smoking at older ages, like age 65. And this is a British study here on the right that basically did pulmonary function tests, and they reported the FEV1 to the middle-aged to older adults, and they said, you, sir, you have the function of a 70, so Mr. 50-year-old goes over and you say you have a lung function of a 75-year-old. And so all of a sudden these middle-aged people thought that they were like prematurely aging. And so quite a few of them took heed to this and stopped smoking based upon ageism, quite honestly. And with also the report that by stopping smoking, that they could convert their trajectory of lung function to those of an individual who never smoked, although it'll concomitant lower overall functionality. In terms of CDC guides for STD screening, so most of the recommendations are for people under the age of 65, but look at the graph here. So you can see the different ages. And this is the percent of increase in office-based treatment of sexually transmitted infections. So this is from a large healthcare system, but I thought it was just pretty provocative to see that that there's been nearly a 25% increase in individuals over the age of 60 who are being treated for STDs. And the other point in terms of STD screening needs to be focused on higher risk groups such as gay and bisexual men. And then for women who may have multiple sexual partners would be a good discussion for exposure and screening. As I mentioned, I'd provide a heat map for latent TB. So these are refugees that come to the United States from these different areas. India and Pakistan, Bangladesh, some of the Southeast Asian areas, Southern Africa, even some parts of South America. And much to my surprise is that there's a sort of an in-between middle-of-the-road rate of tuberculosis from that very populous area called Greenland, as you can see up here. I have, in my entire clinical practice, I've never had a patient immigrate from Greenland, so I don't put that high on my list for worrying about where the TB is coming from in that particular region. But again, just remember that there are areas Here in North Dakota, we're constantly screening Somali refugees that have come to the Minnesota and North Dakota region. Yeah, so the other thing is to screen for geriatric syndromes. So I just wanted to point out that if you apply comprehensive geriatric assessment, which is part of another presentation series that we've done, is that it works. It improves overall physical and psychological functionality. The patients have better qualities of life, or at least that's what they report, and better satisfaction with their clinical care. So even if you didn't have any thoughts about geriatric assessment having an impact on the older adult, it certainly will make them happier with their clinical experience. So for those of us who are assessed by the Press-Ganey reports, we all understand what that means in terms of getting good 5-star ratings by our patients. But that aside, that's not the important part. It's really the impact that geriatric assessment has, which reduces acute care, and it should be a component of the annual wellness exam. So what are the geriatric syndromes? So we have a Benjamin West painting here of Adam and Eve taking maybe a trip or slip fall. We don't know for sure, but it's important, and CMS actually expects that providers will ask annually whether the older adult had fallen in the past 6 months. We like to find out if they've fallen as a geriatrician within the past year, particularly if they've had 2 or more falls. But also what counts is fear of falling. So if somebody is fearful of falling, they have a very high risk for falling in the future. And likewise, you want to ask if they themselves have any concerns about gait or balance. And I want to point out this Medicare Merit Incentive Payment System, the so-called MIPS, have different metrics for quality outcomes in older adults. And one of those is to ask if somebody screened or said that they fell in their clinical exam, that they then proceed to a multifactorial risk assessment for that positive fall history. And it's important to not only look at the intrinsic elements of falls, such as their wobbliness or gait imbalance, excuse me, but also asking them about extrinsic factors such as things at home that might cause falls, such as lack of slip or anti-slip guards on the shower or bathtub, as well as throw rugs in the house that might be cause for trip falls. So the other geriatric syndrome is incontinence, and basically it's just a screening. It's kind of an embarrassing topic, particularly for women, so it's not always their first thought when they come into the clinic, then say, oh, I've got bladder problems, because generally there's kind of a bias, it's kind of ageism that urinary incontinence is supposed to be normal with increasing age, and it's not. So these are some of the questions that you want to consider and ask. Do you ever leak urine when you don't want to, or are you coughing, exercise? And then this one's always big on going on to the way to the bathroom. I always ask whether the individual gets up at night and has some accidents. Enuresis is not such a big deal in older adults, but also that could be another point of inquiry. Well, the big one in geriatric syndromes is cognitive status. So we want to use our screening tools. The quickest one is the Mini-Cog test for memory, and then also the PHQ-2 for depression. And I think most folks are pretty much familiar with those 2 tests. In terms of geriatric syndromes, we want to screen for neurosensory loss, so vision and hearing screen are important. It's a requirement for the initial annual wellness exam by Medicare. And I pointed out earlier that Medicare does cover glaucoma screening, at least initially. And the other point is that audiometry is the gold standard for neurosensory hearing loss, but the whisper test is pretty predictive. And so that's where you stand behind the individual 2 feet and whisper a letter and a number, and you ask them to repeat that. We'll also want to consider screening for geriatric mistreatment. So 2 components here. One is elder abuse, and those might be identified by unexpected or ecchymoses, contusions, burns, bite marks, and genital rectal trauma, as well as pressure ulcers from sitting around, which includes, by the way, heel pressure ulcers that may not have broken open but have softness on the bottom of the heel. And if they have low BMI, these should all be considerations for mistreatment or self-neglect. And I point out Diogenes syndrome, which is one of the more interesting syndromes that we see in geriatrics. These are people that typically are hoarders and are very homebound. They collect anything from cats and books. I had one patient who collected photographs. He was 96 years old and had about 96 years worth of photographs stuffed in at least a couple hundred boxes that were in his Chicago apartment. In terms of social determinants of health, there's a very good scale for loneliness called the UCLA Loneliness Scale, which would be a good tool that I would endorse. You also want to ask individuals if they have any concerns about their money, particularly if somebody has taken their money unexpectedly, and again, if they have cognitive dissonance or memory loss, they may also have paranoia or delusions about people taking their money, as well as authentically somebody did actually take their money. Most oftentimes it's an adult child who wipes out the bank account, and that all needs to be interrogated and followed up either through your own efforts or through a referral to social work, and then through the Department on Aging for elder abuse. In terms of safety check, I think it's important we mention about home environment, looking for anti-slip for the tubs and showers, and also looking for trip hazards. Kind of reminded of this Edgar Degas painting here that shows a woman bathing in a shallow tub, obviously with no anti-slip devices there, no handbars or rails. So that probably would qualify as a bad situation in the geriatric assessment. Also, you want to inquire about assistive devices. So cane length, does it go up to their wrist and no higher? And then also, if they do have assistive devices, do they actually use them? A lot of patients will come in and they'll say, oh yeah, I have a walker, but it's in the closet. You also want to have carbon monoxide and smoke detectors. Make sure the batteries are updated. It's also important to point out to the older adult that their hot water heater not be above 120 degrees Fahrenheit to avoid burns. And then also importantly, consider driving assessment. Typically these are done by occupational therapy, but also you can refer to AARP for their safe driver course, which would be good, but also the driving assessment needs to go hand in hand with the cognitive assessment. So if somebody screens positive for the mini-cog test, you really then need to drill down in terms of what their driving inclinations are, whether they've given up the keys already, limited their driving, or still continue to drive. Well, kind of a busy slide here with immunizations, and I think I just want to bring your attention to a couple of points here, because you can get all this information from the CDC guide for adult immunization, and you should consult that annually because it changes in some respects. So influenza is important to have and prescribed annually. The high dose influenza shot is generally preferred in the 65 and older. The new recommendations for the COVID-19 vaccine, so currently it's one set, whether it's the RNA with 2 doses or the alternative versions with 1 dose, and the follow-up needs to be determined as of when this presentation was put together. The other point that I want to make out here is with the pneumococcal vaccine. So basically, there's a couple of options, but basically you want to give one dose of the 23-valent vaccine unless it was given prior to the age of 65. Sometimes people with lung disease are given pneumococcal vaccine in their 55 to 60 year range, and so then you would want to repeat that. But a discussion needs to be made with the individual about the 13-valent and the 23-valent given consecutively. And if somebody wants that higher booster effect, then they need to be given in a sequence of the 13-valent first and then 1 year later with the 23-valent. You can actually reverse them, but it just depends. Like I say, there's some controversy about the overall efficacy of having both immunizations, but minimally you would want to do the pneumococcal 23-valent. And then you can see here with the other immunizations, hepatitis, Haemophilus, and so forth, those are generally reserved for individuals that have asplenism and then immunosufficiency, including people on medications that are part of the complement inhibitors. In terms of chemoprophylaxis, there's a drift away now from aspirin as primary prevention in the older adults. However, if they do have a 10% or greater cardiovascular disease risk, then mini-dose aspirin is recommended in the what I call the young old. So those would be individuals, at least in a geriatric practice, 65 years to up to 70. In terms of vitamin D, the American Geriatric Society recommends 1,000 units, international units daily, and 1,200 milligrams daily of calcium. There is some controversy about taking calcium, particularly in women, as causing some additional problems that are vascular in nature. So it's important to follow up with the randomized controlled trials that address that issue. However, I would just point out that most diets pretty much have about 1,000 milligrams of calcium in them daily. So supplementation would be, to get that 12 to 1,500 mark, would be basically for women 2 small containers of yogurt daily. There's no evidence that multiple vitamins have any impact on functional longevity or just lifespan. However, there is some evidence that vitamin E may lower lifespan, and so I always point out that be careful with vitamin E supplementation. This is a very popular supplement in some of the anti-macular degeneration preparations, and so I often look to see if people are taking multiple vitamins, particularly things like Ocuvite or these other I-type multiple vitamins, and if they're also on anticoagulants. There might be some interaction with vitamin E as well as with fish oil, and then in addition to some of the anticoagulants like Coumadin and apixaban. In terms of hormonal replacement, it's not recommended. So testosterone does not work in men. It basically peters out in 3 months. So they might have an initial boost in their improvement in symptoms associated with testosterone deficiency, but then it doesn't sustain itself. In terms of estrogen and progesterone replacement in women, it's associated with increased cardiovascular disease, although I have to say that there is some evidence that estrogen replacement may be beneficial in brain function, and so there's still continued research in that area. So it's really important to try to get a handle on the lifespan of the individual. One of the better reference tools is what's called ePrognosis. This is from the University of California at San Francisco. And you can go to the site, you can just Google ePrognosis. And here's an example. So what I did is I put in a pretty much healthy 70-year-old male and accumulated some points. You know, male gender, you get more points, and age, obviously, you get more points. And you can see what the relative 5-year mortality, 10-year mortality, and then 14-year mortality might be. And so sharing that with individuals might be important, because talking about 1 out of 4 chance of passing away within a 10-year period might stimulate some thoughts about, well, not too bad, but maybe I should get my advanced directives in order, and so forth. So these types of screenings are, I think, valuable for engaging in talk about what matters to the older adult, and also to start looking at their advanced directives. And quite honestly, the sooner the better. Everybody should have advanced directives, but as people start approaching 75 years of age, there should be 100% of those individuals with advanced directives. And again, it's important to align what matters with the older adults to the benefits and harms of various screening tests. And so if you want a little deeper dive into what and how you evaluate what matters to the older adults, there's a very good toolkit that's listed on the Institute for Healthcare Improvement website. And this is part of the Hartford IHI, American Hospital Association, an initiative associated with what we call age-friendly healthcare. So I highly recommend that you use this as a resource to consider some tools for yourself. I personally like the Stanford letter, which helps older adults, kind of walks them through with guided questions to answer what matters to them, and then to convey that to their primary care provider. So there's a set of recommendations from the American College of Physicians. So their Choosing Wisely program basically recommends not using PET scans, CT scanning for cancer. I had a commentary by somebody working in a rural area once, where the patient said, "Oh, this Dr. So-and-so is great because he's finding cancer all over the place," and everybody's so grateful. And he was doing basically routine CT scanning, whole body scans. And the problem there is that you find the non-malignant tumors, and it causes a lot of morbidity and mortality just from pursuing those kinds of diagnoses. You also want to consider remaining life expectancy relative to the risks of testing and overdiagnosis and overtreatment, which is the same rationale behind not using whole body PET or CT scans for screening healthy individuals. The recommendation for Choosing Wisely is that you get your colonoscopy, and if it's pretty much normal, you go each 10 years thereafter. And so that's sort of their recommendation. Obviously, if somebody has polyps or a biopsy, and if the gastroenterologist recommends a 5-year follow-up, that certainly makes sense. The other one is dialysis patients. So pretty much they have a 7-year lifespan that's pretty much absolute once they start dialysis, and usually it's much shorter than that. So they don't meet that criterion of a 10 years or greater lifespan that would warrant further cancer screening. So want to ask questions a little bit here about the Welcome to Medicare exam, and we want to look at the annual wellness exam. So the Welcome to Medicare visit has various components. They're basically, on the left side here are the assessment part of it, and on the right side are the action plans. And so many of these are straightforward. They're just like a regular HPI and physical exam. So you want to look at the past medical and family history, surgical history. Minimally, you have to measure blood pressure and BMI. However, we like to measure other things such as pulse oximetry with walking and gait speed, which we'll talk about. But also in terms of the screening process, so vision and hearing are required. Using the mini-cog for cognition would be great. You can use other tests for screening memory loss. Depression screening, again, would be PHQ-2 or PHQ-9. Geriatric Depression Scale would also work. You want to look at functional ability, so that they have any deficits in their activities of daily living or instrumental activities of daily living. And you also want to assess for safety. So, traditionally, usual clinical practice, we would say, do you wear seat belts or do you wear a helmet while you're biking? But in geriatrics, you want to ask, have you had any accidents while driving? Have you had any tickets or near misses or citations? Has anybody shouted at you to watch out while you're driving? These are all indicators that there might be some driving impairment, either associated with dementia or neurosensory problems. And then it's important to for the action plan for the Welcome to Medicare to create a schedule for current and future screening services. You want to also include some educational and try to personalize it. There are different techniques that you can use to identify goals. One is called target practice, and so you ask the patient to point out on this target to list what's in the bullseye, what's most important to you there, and then moving out to the periphery for things that you might want to address down the road at a later point in time. The annual wellness exam basically is outlined here with all the different elements that I just talked about. Also, you need to include medication review. Interestingly, they require you to put down all the providers that the individual is currently working with, and so that includes both specialists and primary care. Presumably you as a primary care provider are that individual. However, they want to know all the specialty care, the ophthalmologist, the cardiologist, and so forth. We talked about the geriatric components of memory assessment, depression screening, and fall risk by doing gait and balance exams, and we'll talk a little bit about what those consist of. Lifestyle changes, and then finally talking about advanced care planning. That all this creates a personalized health prevention plan. In terms of health risk surveys, so these are just some recommendations. You can measure quality of life. There are tools for doing that. You ask about general health. Nutrition, hearing, sleep. Sleep is an important one because nearly 1 out of 4 to 1 out of 5 older adults have insomnia. You want to do a home safety check and look at their fall risk. I guess I put that down twice here because I wanted to emphasize it. And then also driving issues, as we talked about. In terms of the health maintenance, these are things that we've covered earlier. I just don't want to go over them again. Just point out that the annual wellness exam should cover all these points: vaccination, cancer screening, infection screening, endocrine screening, so diabetes, hyperlipidemia, and osteoporosis. It's also important to include in this evaluation the social determinants of health. So there are some health systems that actually have a checklist for these, and there are various tools that you can use that cover all these different areas, such as financial well-being, if there's any food insecurities, transportation. And a lot of times these questions are asked by the med tech or the nurse prior to the individual coming in for the Welcome to Medicare exam. In terms of physical assessment, some of the important points are to do the blood pressure, height, and weight. I like in terms of, and I've divided this up into face-to-face meetings in the clinic versus telehealth, and some of the limitations of telehealth versus the advantages. We can talk about, but I've just parsed this out in terms of some of the things that you can do. So, for example, in telehealth, you have to ask about blood pressure because unless there's somebody there facilitating the telehealth visit, the individual, the older adult, would have to check their own blood pressure. I think, importantly, a question to look at is, and to ask yourself as a provider as to whether the patient looks their stated age. If they look older than their stated age, then chances are that they actually are biologically older. And that's an important indicator for what we talked about earlier with the e-prognosis, or identifying how much remaining life expectancy the older adult may have. In terms of gait and balance, I really advocate gait speed. Anything less than 1 meter per second is considered a risk for falls. Sharp and Romberg is where you put one foot in front of the other, and that's a good balance test for screening for fall risk. In terms of neurosensory exam, Snellen charts, whisper test, and checking for cerumen are important. You can see on the balance of telehealth that you can ask the individual to read a newspaper and report if they have any problems. In terms of neurology, I like to evaluate patients for frontal relief signs, so certainly the glabellar test and the snout reflex. Also check for cogwheeling, various sensory elements, including vibratory. So vibratory sense goes down with increasing age. However, if somebody has loss of vibratory sense in their fingers and in their feet, you might consider heavy metal toxicity as an example. And I've picked up a couple of cases of that just by focusing, or including rather, vibratory sense in both the upper and lower extremities. In terms of memory testing, the mini-cog or the telephone inquiry for cognitive status, the tics. You can also use the 88 and ask the caregiver or spouse if there are any indications of cognitive impairment for the patient. Some of the other points that I want to make is in terms of the clinical exam, you want to look for proximal muscle weakness, which might be associated with polymyalgia rheumatica. A lot of times the individual will report that they're having problems getting up the stairs. They have to stop after a couple of steps. And also check for heel softness. This is often overlooked, particularly in the sedentary older adult or the wheelchair-bound older adult. So always check. So the softness is, firmness on the tip of the nose would be normal for the heel. If you feel the side of your nose, that would indicate a softness that would represent a heel unstageable decubitus ulcer. In terms of functional assessment, you want to do the activities of daily living and instrumental activities daily of survey to see if they need partial or full assistance. In terms of functional performance, there's a couple of ways that we can test, like gait speed or the timed up and go test. So the timed up and go test here shown, this is either 10 feet or 3 meters. You walk out to a point and then you walk back, and that all should be done within 15 seconds or less. You can see at the bottom part here, a little hard to read, but just basically the red zones are indications of where slow gait speed, so less than 0.6 meters per second, is associated with functional impairment. And then the next level, it's associated with future hospitalization. And then the third component here, less than a meter per second, is associated with high risk of falls. So gait speed tells you an awful lot, and that's why I advocate using that as the sixth vital sign. So the annual health plan needs to be written. As mentioned, you provide a screening schedule, a health maintenance schedule, what preventive measures are going to occur, and then also to really hone in on what matters, which includes advanced care planning. So just to summarize the annual wellness exam, it's a great opportunity to clarify what matters to the older adult. I mentioned my preference for using the Stanford letter, which I think is very helpful. It's a little long, so you have to have this go with the patient and then they bring it back. Sometimes there's an advanced care planner at the clinic that you can refer to that can help with this. So it's also an opportunity at the annual wellness exam to motivate older adults. So I find that the SPRINT study is very informative. You know, usually we consider adequate blood pressure control between, basically 140 systolic, but the SPRINT study indicates that if you have a highly functional older adult, that you want to push that blood pressure control even tighter to 120 millimeters of mercury. And so I think that's important to consider. In terms of physical activity, prescribing both resistance, anaerobic, as well as balance training have to go hand in hand with all three of those in order to be effective. In terms of nutritional counseling, I'm an advocate of the Mediterranean diet, and there is evidence that there's better quality of life and also a reduction in brain atrophy over time for those that are in a Mediterranean forward diet, specifically or particularly amplified with fish products. and then also to consider social engagement. So if you got somebody sitting at home and not socially engaged, that could be a trajectory into functional impairment. And so it's important to get the individual out and socialized in some manner, and that may be in discussion with the spouse or with the other family members. So just to summarize prevention, the whole goal is to try to preserve functional independence. There's a lot of the randomized controlled trials on primary and secondary prevention exclude the oldest old, so we don't know a lot. We have to infer from those studies, and again, to balance it with active life expectancy. However, I want to point out that individuals that are 85 and older are amongst the highest percentage of growth in the overall population in the developed world anyways. And so we're going to be seeing people living closer to 100. And so if you have somebody who's highly functional at 75, a lot of these screening measures might be appropriate for those 75-year-olds. So you need to really kind of estimate as to whether this person is going to live 90 to 100 to consider a discussion about further prevention. So there are various sources that we use to help guide us in our preventive measurements. And importantly, we need to balance all of these different kinds of screening tests that we do, particularly cancer screening, with what the functional status is of the older adult, as well as their cognitive status. So if they have moderate dementia to severe dementia, it really doesn't make sense to do a lot of these screening assessments. And likewise, remaining life expectancy. So if you get somebody with 5 or 6 chronic conditions and they're 75 years of age, the remaining life expectancy is barely going to be 78 to 81. So really they're under that 10-year threshold, and you would likely consider not engaging in any type of screening from that point forward. And again, just to really reemphasize the fact that one of the geriatric 4Ms is what matters, and so it's really very important to hone in and understand what the goals of the older adult are or may be in order to create a patient-centered healthcare plan. So that's the conclusion of this presentation. I appreciate your attention, and I look forward to seeing you on the additional modules that we have as part of this Dakota Geriatrics program to try to enhance geriatric knowledge and skills in clinical practice. Thank you.